So these little talks now are kind of more rapid fire. There's several little things in order here to get to the home health care piece. But transitions in care, it is a huge issue. I don't know how much you read about healthcare systems, but once you get into them, you will understand that transitions in care has become a big deal. So much so that they now have billing codes for transitions of care. There are transitions of care codes. And they're very specific from hospital to clinic care and other areas. Anytime patients move locations, you can actually bill for some of the coordination, some of the follow-up, some of the integration of care that needs not to be done. So anytime the government comes out and recognizes a new payment code for transitions of care, that tells you that it has kind of hit the radar screen, because they're not paid for anything that they don't think really is of great benefit. Let's look at some of these issues about transitions of care. It's a big area of research in health and will remain so. People over age 65 and the elderly account for more than 36% of all healthcare utilization, which I think is pretty obvious, including home health care, emergency room visits, hospitalizations, and prescriptions. Now, ER visits by the elderly, that's the fastest growth of ER use compared with other groups. There's more and more older people, and as they get sick, their first point of contact might be through the emergency room. They require more staff time for evaluation, and you can see now why that would be the case. They require more lab and or other studies for evaluation, and they're more likely to be admitted to the hospital, just as part of having multiple diseases over a long period of time. The 1999 Institute of Medicine report, this is kind of like a sentinel document. I wouldn't go back to 19 years ago if it weren't a big deal. The 1999 Institute of Medicine report kind of kicked off all of this focus on transitions in care, which has gone on now for almost 20 years and resulted in some of the things that we'll be talking about already. 44,000 to 98,000 Americans die in hospitals each year as a result of medical errors. Okay, scary. There's commission errors like just give the wrong diagnosis, give the wrong medication, omission, delay in diagnosis, failure to follow up on test results. You can see how that would happen even from your time at Good Shepherd. You know, where is stuff? They do it, but where is it filed? And you just spend so much time tracking, stuff down. Let's see here. Okay, here's just some of the, 100,000 unintended deaths occur in the hospitals in the United States is equal to a jumbo jet loaded with passengers crashing each day for 1 year. Just to kind of give you a sense of how much stuff can happen in the environment. Okay, since the 1999 Institute of Medicine report, many books have been written about safety, so you protect yourself in the hospital, keeping patients safe, how to survive your hospital stay, To Err is Human, very famous book, Internal Bleeding, Wall of Silence, just all kinds of titles to give you a sense of what's out there. You almost don't want patients to see all this because it would scare them about going in for care. Okay, now many things go right in the healthcare system, but there's a lot of things that may not. Okay, local press coverage has been out there. You see it all the time. If you scan the Daily Oklahoma, you can find health-related news, shocking and otherwise, all the time. Patient's family accuses local hospital of negligence. That's a common headline. Medication mistakes are costly, study says. That's true too. Many studies of the problem have happened. There are deficits in communication and information transfer between hospital-based and primary care physicians. Just think about that. If your patient has been in the hospital, how often do you actually get all the information of what was done in the hospital stay? It's very common for a patient to come sit down in a primary care visit and tell you they were just in the hospital and you can't get anything about what happened. What did they tell you that you had? Did they give you a new diagnosis? How did they change your therapy? All just through a patient, and you just can't find it. We had computers in our clinic, and we would try to log back into OU Medical Center Hospital, where a lot of them were admitted, just to find stuff. And there's another problem. The outpatient computer system and the inpatient computer system were two different computer systems, and they all had their firewalls to keep outside people from getting in. So it's like, well, let's just keep it all locked up so nobody can know anything about anything. It was maddening. Okay, direct communication with here's some of the findings of this study. Direct communication between hospital physicians and primary care physicians occurred infrequently, 3% to 20%. Okay, the healthcare provider taking care of the patient in one environment rarely talks to the healthcare provider taking care of the patient in another environment. Really bizarre. Availability of discharge summary at the first post-discharge visit is low, 12 to 20%. I am a witness to that. I can tell you, like 1 in 5 patients will have information, but roughly. Incomplete information regarding results of diagnostic tests, discharge medications, patient, family, counseling, and follow-up plans. You just don't get it. Okay, now this is the Swiss cheese model. You'll see this picture a lot when you look at transitions of care. Okay, just kind of look at it. These are all the little systems that are in place, and all of them have their holes. So it's like the safety net's got some gaps in it as you kind of move from place to place. So here, you have non-standardized care taking place, even though people are working hard to take care of you. Because care is not standardized in a facility, some people have things done, other people do not, so that one moves through. And it might be a standard of care that's important for the outcome of the patient. Okay? There are system failures. You know, discharge, it's intended that everybody have a hospital discharge counseling session where everything is gone over. They don't all get them. They're supposed to, but they don't get them. Or somebody might come in and give you a piece of paper for a minute and say, if you have any questions, call us. They can check off the box it was done, but it really isn't done, and the communication didn't happen. So the system has a good intention, but there's a failure, another hole you move through. Poor communication, even though you have smart caregivers. So when you have providers in two environments that don't communicate, they're not dumb people. They both know stuff, they both have good intent, but because they haven't connected the dots, another hole can happen, a gap. And then finally, you have patients who want to get well, but the patient may not do stuff. They may not state the discharge summary. They may throw the paper away that says what to do. They may be told to call back in 24 hours to report how they're doing, and they don't call back, and then you can't find them on the phone. So with stuff like that, when you add all those things up, non-standardized care, something didn't happen, system failure because people didn't communicate, and then the patient doesn't do what they're supposed to do if they understood it. You add them all up over time and things happen, big things. So now the Joint Commission for Accreditation of Healthcare Organizations, the JCAHO, and I think most of y'all heard that, right? Most of you heard the Joint Commission, called the Joint. I wouldn't say affectionately, but it's called the Joint. By hospital people have to deal with it. They now state implement a standardized approach to hand-off communications, including an opportunity to ask and respond to questions. Okay? Transition of care is, by definition, a set of actions designed to ensure the coordination and continuity of care between different locations or different levels of care within the same location. I will tell you, when I worked in the hospital, and when I first started out, you could go from the ER to the floor, from the floor to the unit, from the unit to a rehab step-down unit, and stuff got dropped all along the way. They're just little problems, just little things pop up that can be very big. A lot of times it had to do with medication changes. We're going to move you from this to this. We're going to change the dose, but it won't get really clarified, and then you'll go back and look at the last record you had, and it gets given the same way again. Then the problem happens. It seems like stuff like that shouldn't happen, but it's actually very easy to happen. If you work in the system, you know how that can happen. So here's just a whole bunch of ways, you know. If you're in the home, you can go to the emergency room, and you can go back home. That's one thing that can happen. You can go to the emergency room and you can end up dead, okay, because whatever problem you had resulted in death at that point. You could go from the emergency room to the hospital. You could go from the hospital home. You can go from the hospital to a skilled nursing facility. You can go from the hospital to a rehab unit, and then all of these can go back to home. All this picture is showing is the many different arrows, many different connection points. And in the hospital, there could be 3 levels of care. You know, inpatient, ICU, maybe CCU, and then step-down unit. Or surgery. That's a scary one. Floor to surgery, post-op, you know, pre-op, post-op, back to the floor. A lot of stuff can happen in there. Okay, it's just the way the hospitals work. Okay, so here's the little ambulance coming by, upside down. How cute. Okay, thank you. Transition of care. Okay, transition of care points and medication errors. Medication errors are one of the leading causes of injuries to hospitalized patients, without a doubt. About half occur during a transitional point of care, where it's just not real clear what needs to move on and what needs to be DC'd and what needs to be changed to a different route of administration. Okay, here's a lady with her pill bottles. That's actually kind of mild. I got a picture here later. I had a patient, when I started working at the VA outpatient clinics, they just had so many people who were just so medicated. I mean, it's just, you can't believe it. One lady came in, and the director of pharmacy said, I was down in the clinic, he said, you need to talk to this woman because I don't know what to tell her. So I said, go ahead, come in, sit down. She sat down. Her husband had just died, and he had heart disease, heart failure, all this stuff. And so she sat down, and I said, well, how can I help you? And she said, well, I want to know if I could bring these medicines back, and they might be used by somebody else, and whether y'all would pay me for those medicines back. Well, there's just a lot of problems with that. Number one, we don't take medicines back once they left the building. That's number one. Nobody does that. That's a safety issue. How do we know she's not a poisoner, putting things and giving? We don't do that. And then, so I said, well, what do you have? And she said, well, let me bring it in. And she had a bag, a grocery bag, about this big grocery bag. She took it all out. I mean, like 50 to 60 individual items, and I kind of grouped them. She had all kinds of medicines. And the first thing I thought is, no wonder your husband died. He didn't take anything. I mean, they were all full bottles of stuff like nitroglycerin paste, you know, all these tubes, beta blocker dose that were taking, aspirin, just all of it. And I said, well, it looks like your husband didn't take a lot of medicines. And she said, oh, honey, they send us bottles to the mail like we all get out. And that happens every time you transition care in the VA. They might put a new order. You might go to the pharmacy. It might queue it up because it's all kind of automated. So they had actions, and I said, okay. And she said, and he never really knew how to do it all anyway. Nobody ever told us anything. It's kind of like, oh, yikes. But I took a picture of it. It's a table full of medicines. And I'm going to show you a picture here that's like only about a third what that table looked like. But it's a mess. Okay, so those, it's real. The types of medicine errors that happen, omission, forget to give the medication, and that happens in hospitals. I mean, it's amazing to me that medication administration is not 100% perfect. It is not anywhere close to 100% perfect. And this is just terrible, unethical practice. There are times where people get behind and they get way behind the dosing interval. Antibiotic Q8. Okay, you got to mark it down at the times given. Okay, let's say somebody got distracted and it went all the way over here to 8 hours later, so the next dose is given. You're not going to do a double dose. So what they will do is write in the medication administration time as if it were given when it were not. And so you're going back and looking at the medication administration records, and it looks like they've received all the doses, but you know all the doses haven't been given because one is still in the cassette of medication. So people are signing things to not look like they didn't do their job. Okay, so there's a lot of that trying to hide from mistake. I know y'all don't do stuff like that, but I'm telling you, get under enough pressure with people watching what you do, and things can happen. Duplication, medicine given twice. Somebody gave it but didn't sign it out, so somebody else gives it again. And then they sign for it. Now it's twice. Now the person zonked out. You don't know why. Dosing error. pull up the medicine dose wrong, drug interaction. Okay, here's some of the bags of the types of things you can see that people will bring in. This is kind of like 1/3. This picture was actually in the family medicine clinic, but the lady I had, her stuff was about 3 times bigger than that in the biggest bag that you've ever seen, and pills and everything. Some of them are labeled generic, some are labeled brand. People don't know. The brand is one color, the label, the brand name, the generic is another color. They can't tell that the green tablet or the blue tablet are not the same thing, and they just take it all. Or not take anything, one or the other. System redesign in ambulatory medicine, there's 5 basic principles that should happen. Reduce reliance on memory, that's a principle. Improve information access. That's why there's big, the government with Obamacare really wanted to move towards a single medical record for the whole planet. Now that would be fabulous. I'm a big proponent of that. If we had one health record everywhere. The reason why it won't happen is that you have so many different proprietary entities and they have legal liability for their information and they don't want their information in your hands. Even though it's the patient's information, they protect it so you can't really connect hospital to clinic to patient because there's the HIPAA stuff. So the federal government makes these rules that make it hard to have what makes sense. Of course, it's also exorbitantly expensive. If any of you have ever been through a computer implementation or a computer system change in the health system, the whole world is gut-wrenched for the whole time the computer changes. I mean, like, terribly gut-wrenched. Because it's always a big to-do. You have to strive for an error-proof system, have to figure out where the errors happen and put in place systems and practices that eliminate the errors. Standardize the process of care. We'll be talking about that on the day that the planet blows up for the final time. Okay, it's a goal to shoot towards, but it's hard to achieve it. And then emphasize error avoidance when training medical personnel. Every accreditation standard in healthcare education for every healthcare provider has issues about safety, health system, and that type of thing. And you have to document you've done it. Okay, you've had little pieces of information all along, and in the capstone class we actually do a thing from the Institute of Healthcare Improvement, which goes through a series of online modules about health systems, safety, error prevention, and what can happen. It's actually pretty good, but it takes some time. Okay, but it's a good thing. I've done it, and I learned stuff. Evidence-based care transition models, you don't have to remember these, there's just a lot of them out there. Transition care model, that's what the codes are called right now. The transition cares are TCM codes, TC codes. These are just some things that have been experimented with: Bridge program, GRACE program, Boost program, all kinds of programs. Okay, discharging to home is a big issue from any system. Team approach to good discharge planning is important. As Casey was telling me, there was just so poorly done, so weak, not that helpful. You have to involve caregivers. When a patient is sick and they're getting ready to go home, what kind of attention span do you think that person has? That's 0. They're either gorked out from the medication the night before that helped them go to sleep. They can't remember what you say. So it's always good to have somebody around. Discuss with the receiving team, review medications, discuss with the receiving team, that is, what system are you going to, and you have to have accessibility to the sending team. So a hospital that discharges somebody to their primary care provider, to home and then the primary care provider, really ought to make some connection, and there ought to be ways to get in touch. What is your experience when you call a hospital to get in touch with practitioner X? Good luck. Just put it on, just put it there and work on something else while the phone's doing the music. I don't know. I have done this before for fun. I've done something in here. And I'm sitting in my office and just put the phone on, just let go. I'll just go 30 minutes later. People say, "What are you doing?" I said, "That's not my music." But I'm just waiting for somebody to respond to me. You gotta make a joke out of this stuff, otherwise you're going crazy. Okay, and then you have to have a nice discharge summary. Hopefully those are done well. Anticipatory guidance. This is something that should be thought about when a patient's moving through the system. Okay, what's the next level of care? Are there any medication changes? What happened during this hospital stay? What did not happen during this hospital stay? You'll be surprised how many patients really don't know what happened to them in the hospital. Did you have a surgery? I don't know. They took me to a room and gave me medication. It might be a procedure. It might be a diagnostic test. You know, and then they're kind of knocked out when it's going on. So they said, well, they took me back. I think they did something to you. Well, where did they do it? I don't know, but I have a bandage over here. Hey, I'm serious. People do not know exactly what happens to them in the hospital, and you'll not know how that can be. Or they won't know their new diagnosis. I always want to ask them, tell me what they told you you had. I just want to know, what did you have? What did they say? Did they say you had a stroke? Did they say you had a heart attack? Did they say? And I've had people who don't know what they have. I mean, they're sitting there they're perfectly okay people, and they won't know what happened to them. Then maybe they had lacunar infarcts, and they were just kind of off a little bit. And so I'll say, did they say you had a completed stroke? Did they say something happened to your brain? Well, they said I had something, but that it wasn't bad and probably nothing to worry about. I said, but what exactly did they say? I don't know. Did you have a heart attack? No, they said there was something wrong with the heart, but I don't think they said a heart attack. It's the words. Did they say myocardial infarction? Did they say this? Sometimes you can hit it, and sometimes it's just all Greek. They just don't know. And then trying to go through the medicines, I give up. I just have to bring the bottles. Let me look at them. I'll just look at them. What are involving caregivers? You have to think about the caregivers with transitions of care. What are their needs? What are their emotional, physical, and medical needs? Because somebody's taking care of people, and they need to be thought about too, because that's your link, to help for that person. Can they perform the required functions? Can they give medicines? Can they change dressings? Can they watch for side effects of medications? Okay, what if you have two elderly people? One's in the hospital, they have surgery, and there's kind of like some nursing care things to be done, and they teach them at discharge what that is, but the wife who's going to take care of the husband really can't see to do well, so they're kind of going home and they really don't know, the healthcare team doesn't really know that the plan can be executed when they get home. So that's why you need to pay attention to who's doing stuff. Do you have help? And then these are two resources, Care Transitions and Nursing from University of Pennsylvania. Just lots of resources about care transition. But if you type in transitions of care, safety, your Google search engine just explodes with stuff. It's just all over out there. Okay, any questions about that? Okay, so now we've got the healthcare environments, and we've got all the transition stuff that can happen when you move between them. Now let's go to another place. Let's see here. That one. Okay, let's go to palliative care. Okay. All right, you've been in the healthcare environment, things have happened, but things have eventually not gone so well, so you're moving to that point where you need to start making the patient comfortable. Okay, so this is another whole area of medicine. There are palliative care physicians, there are palliative care programs. Does anybody here know anybody who does palliative care as a job? Okay, it's kind of new. But it's catching on, and it's a whole philosophy and way of thinking about managing patients that's somewhat different from what we've done in the past. I kind of want to talk to you about what we've done and what we're doing and what that is. Palliative care involves all kinds of comfort measures, so it might be feeding, it might be pain management, it might be stress management. There's a lot of things that can happen when it's not likely that somebody's going to do well long term. And you have to use the term not likely because nobody really knows what's going to happen to somebody the next day, even though you might be pretty certain you never know.
Finally tonight, deciding what's important and preparing for the inevitable. A conversation about the end of life. Jeffrey Brown has that.
I learned about a lot of things in medical school, but mortality wasn't one of them. Words written by a surgeon, but if you take out the reference to medical school, probably true of most of us. We might learn to live, few of us learn to die. That is the subject of a new book titled Being Immortal, and the aforementioned surgeon is also the author, Dr. Luwande. Welcome to you.
Thank you.
There are two facts of life you seem to focus on. One is that, yes, we all age and die, and the other is that we don't seem to understand it very well.
No, medicine has taken over mortality in some sense. We are responsible more and more for trying to fix the problems of aging and dying, but we don't know how to do it. And I think the thing that I discovered was we have a fundamental failure. We don't recognize that people have priorities besides just living longer.
Why do we not understand that? I mean, that we want to live longer, but we want to live longer in a certain way with certain values and beliefs.
Yeah, I think you're exactly right. Some people will say, it's really important to me that my brain works, that I am who I am. Other people will say, look, I just want to know that I'm not suffering and that I'm not in pain. Others will say, I have a life project that's really important to me. And the fact that we in medicine, we prioritize health, safety, and survival. We think that that must be what people place first. But in fact, we make choices all the time in our own homes about risks we take. And one of the consequences is that in medicine, as we face problems we can't fix, like aging or a terminal illness, we often sacrifice the very reasons that people want to be alive.
You're writing about your profession, you're writing about some large societal issues, but you write about it in very personal terms, in your own family, right?
I interviewed more than 200 patients and family members about their experiences with aging and serious illness. I tracked geriatricians, palliative care specialists, nursing home workers, and my dad along the way got a diagnosis of a brain tumor in his brainstem and his spinal cord. And I realized the stakes of this was, how could we make it so that he gets every chance he has, but then that we're also not making him suffer right through the end and taking away things that are really important to him. What I found is that it's pretty simple. Priorities really matter for patients. The most reliable way to know people's priorities is to ask about them.
Just ask.
And we don't. We don't in medicine.
Well, why is that? I mean, it seems so, I read it and you say it and it sounds obvious. Just ask. What is it that you want when you're at the end of your life? But doctors don't, even family members don't.
Well, first of all, it's the words, right? That's a really painful set of words to say to somebody.
Yeah.
What do you want? At the end of your life, you're saying I'm might as well give up now? What I found was tracking people who are really good at these conversations, they ask the questions in very different ways. They ask, well, what's your understanding of your condition? And people will also often say, well, I know I can't be cured, but I might even die. Then you say, what are your fears and worries for the future? What are the goals you have if your health should worsen? And what are the trade-offs you're willing to make and not willing to make? And asked that way, what you're saying to people is, I want to know your priorities. Besides just being a, pulsing body alive, but not getting to have life, not really living.
And all of this, of course, in a society that we're living longer, technology allows that, so these kinds of issues come up ever more. I don't think there's probably not a person listening to this that hasn't faced it in some way.
That's right, either because we ourselves face it or we have a parent that is facing it. And the difficulty is all of that success, our ability to have technology that can always do something more. We can put you on the ventilator. We can give you another round of chemotherapy. That we haven't learned, well, what does it mean to even die? And then going further upstream, what does it mean to make choices where some of these things take away quality of life that we care about even before you die? And I think the answer is that we haven't had the words around articulating what our priorities really are. For example, doctors, our approach used to be 50 years ago, it was doctor knows best. Paternalism, we're going to tell you exactly what you're going to get, and we're not going to actually tell you what's going on with you. And we rebelled against that in the 80s and 90s. We moved to doctor informative, almost a retail mode. Here are the options A, B, C, D. Here are the risks, the benefits, the pros, the cons. What do you want? And people would say, well, what do you recommend, doctor? And I was actually taught to say, well, it's not my decision, this is yours. What people want is a counselor. An effective counselor is someone who can talk to you about, what do these numbers mean? What are you actually worried about for me, doctor? And then let me tell you my priorities and help me choose which option will meet them.
Do you see that changing in your profession? Do you see a better understanding of the empathy that's required to ask the kinds of questions you're proposing?
I think we actually are full of people in our profession who have had that empathy. If I can judge from my own situation, I wanted to do better. I tell the story of a 34-year-old woman diagnosed in her 8th month of pregnancy with terminal lung cancer, and we actually spoke about the idea that we did not want to be on the train all the way to the end, to the point that she never had time and quality of life, because she knew it was going to be incurable, but she wanted the best possible treatments. And yet we took that train right off the cliff practically. We never got off with making sure that quality of life got there. And I think the reason why is we have anxiety about asking these questions, patients, doctors, family members, because we haven't had the words. And I think we know now increasingly more about what people who are really good at these conversations do, and it's important to understand they are a skill. They require asking a few of these questions, and you have to ask them repeatedly over time because people's priorities change as time goes on.
All right, well, we'll continue our discussion online, and for now, the book is Being Immortal. Dr. Rwanda, thank you so much.
Thank you.
Now, isn't that interesting? Now, that's something you'll have to think about. It may not be where you are in your space right now as a student, because this is so artificial. I mean, you're just in the room all day and you just get all kinds of information given to you. It begins to be more important when you get into your clinical phase and you're actually interacting with people. You will still not have the responsibility of this discussion with anybody as a student learner, but you may be exposed to people who are beginning to have that dialogue. And I think it's very important to understand it now, because every interaction with a patient is a step towards relationship, which is a step towards honesty, which is a step towards, can we talk about the stuff that has to be talked about when the time comes. So you're always developing a relationship with your patient so that you can say these things, ask these questions, and get legitimate answers, and they will know that you truly are interested in that, because you kind of show who you are all the time with patients. If you're always in charge of everything, then maybe they get to a place where they don't really want to be in charge of this part of their life, because that's the type of person you are, and I need somebody who's a little more fluid with me. And there's others who, who are very dependent and kind of like that. So you're going to have to learn your patients and have relationships so that when you get to a point, and it happens with, you cannot be in healthcare and not come to this point with somebody somewhere, be able to at least talk to them about where they are, okay, in their journey. Okay, and so what we're moving into in palliative care as we move through home care and hospice care, you start moving into philosophy of yourself as a healthcare provider. What is that? There's what you need to know to manage people medically, and then there's what you need to know to be a healthcare provider with a person humanly. Okay, and they're all part of this continuum of what you need to know. So this presentation kind of moves all the way down through tomorrow's issue on spirituality. It's that ultimate relationship with the patient. So it's the art of being a patient care provider. And you have to kind of think about these things a little bit, even if they're uncomfortable, because they will show up. Okay, Dying in America is a book that was put out by the Institute of Medicine, our friends, about improving the quality and availability of medical and social services for patients and their families to enhance life through the end of life. may also contribute more to a sustainable care system. Okay. The key findings and recommendations that come forward in this book: delivery of person-centered, family-oriented end-of-life care is needed. Okay, we've had patient-centered. This is person-centered. There's a little bit difference in the language. They're no longer a patient, even though they're a patient. They're a person, okay? Just like you're a person. So you have to be person and family-centered. Clinician-patient communication and advanced care planning is essential. Professional education and development is needed in medical education. It's often overlooked. There are many healthcare providers out there right now who have never talked about this in their development. It just kind of happens in dialogues with people on the side, kind of sideline. Policies and payment systems are needed to support high-quality end-of-life care. See, a lot of things in healthcare don't happen because nobody pays for it to happen. So the financing of healthcare almost dictates exactly what it is. Okay? And you will be part of the generation that will continue to push back against things and to carve out something that's better. And my generation pushed enough to get to the place of looking at these realities in patient care, and yours will get to take the next step as voices. Public education and engagement is needed. Okay, we know this, the leading causes of death in the United States, heart disease of some sort is the top, cancer is number 2. Okay, if I ask in this room of the people you know who died, what they die from, it's going to be heart disease or cancer to a large extent. And then you've got cerebral vascular disease, stroke, lower respiratory diseases, okay, pneumonias and stuff, accidents, and diabetes. And diabetes might be, the result of the disease of the heart or the cerebral vascular disease, so it gets embedded in this. Look at phases of serious illness. Okay, this is kind of the way it used to go. Okay, phase 1, healthy or with reversible illness. This is where advanced directive might be a good time to put in place. Everything is okay, you think about what you want. And you have disease progressing along this axis, and then you have chronic and curative care being done. Okay, we're treating your lung disease with all the medicines that we got in breathing treatments, but we might also do some things that are palliative care. We might give you an anxiolytic so you're not so stressed, about breathing, etc. And then as you move further along in disease progression, you see that palliative care is a larger part and chronic and curative care is still happening, but it may not be the largest percentage of all the things you're doing. Early on is that chronic conditions. Then, and this is where advanced care planning can take place. Phase 3, progressive frequent complications. Okay, you all know people, they end up going in the hospital several times a year. It's kind of that end phase is beginning. Palliative care becomes more important. And then finally, palliative care is almost everything you're doing because there isn't anything that's curative anymore. And then the phase 4 is hospice eligible, and then you do hospice. So what do patients want? Okay, mostly they want pain and symptom control. Who wants to hurt? I mean, if I'm there, I want pain control. That's going to be on my advanced directive. I want pain control. I don't want to be sitting there suffering. Avoid inappropriate prolongation of the dying process. I'm not going to be a respirator person. I just know that for me. There's some people who are respirator people. I'm not a DNR. I'll probably be a DNR. Just depending on the circumstances, make that decision. Achieve a sense of control. People do want to be in charge of where they're moving. They want relief burdens on the family. They don't want them stressed and drug into a room every so often to figure out what to do. And they want to strengthen their relationship with loved ones. As people come to the end, they want things to be made right, mostly. Okay? Not true for every person, but mostly. Last month of life for a cancer patient right now, what happens? Look at this. Chemotherapy is 40% of their energy and effort. Yeah. Emergency department visits, 48% have that happen. Hospital admissions, 50% have that happen. No hospice referral. 1/3 of people never get hospice. They're just sick until they're dead. And then late hospice referral, median of 16 days, that means at the end is when they finally start acting like they're at the end, when they actually were probably in the end for a lot longer than that. and therefore they don't have time to do these things that they want done. The consequences, there's a high 30-day hospital mortality rate, okay? Because when you don't do anything to the end, then you're in the hospital, then it's all the emergency stuff, and it just goes to crump. There's a lot of suffering that may not need to happen. Costs are through the roof, and opportunities are lost for these relationship issues that need to be attended to. I think the cost thing is crazy. You know, my dad, when he was in the end of life, he just said, I'm not dragging every resource I've got into the grave. Some of this stuff is ridiculous. And he was very aware of that and didn't do it. And as a consequence, died fairly quickly, but didn't drag all the resources down. Because he was a farmer, and they are just, they're frugal, they're thrifty, and they're practical about stuff. And it's like, why am I going to be on a respirator and do all this junk when it'll cost this place, you know, who knows how many $1,000s every day, and I'll live a little bit longer, and then just drags all the resources down. So they are very thrifty in that way. And for those of you who work out in the rural areas, you know how people are going to look at stuff. They look at it differently. And in the end, he was right. You know he was right, because he left everybody in a good place. The traditional model of care for patients with serious illness, they get diagnosed, it's just curative. Everything we do for you is to cure you. Then we start taking care of the other symptoms. Then we decide that nothing can happen and you're going to die, so we do hospice, and then you get bereavement care. So palliative care has a place, okay, maybe more than what we thought about. Its specialized medical care focuses on providing patients with symptom relief, pain relief, stress relief, whatever the diagnosis is. The goal is to improve the quality of that person's life for the length of time they have. It's usually provided by a team of people. You know, it's not just going to be one person in there. They work together, and they provide an extra layer of support for the medical team that may have been part of the curative team or part of the medical management at that point. Okay. It is appropriate at any age and in any stage of a serious illness and can be provided along with curative treatment. I know people who have illnesses that we would probably keep, you know, slugging away in a curative approach, and they will tell you that for them, the efforts at curing is not worth it to them, and they would rather go to hospice. And people kind of go, why are you doing that? And it's like, listen, I don't want to be stuck every day. I don't want to be in the hospital. I don't want this kind of stuff. I want to go home. I like my home. That's where I want to be. If it's no big deal for you all, thank you, I'll just go home. That's happening more than you would think. And of course, the healthcare teams, well, we can do this and we can do that. It's like, okay, just let the man go home. How it works, it's team-based. It's collaboration with primary physicians, so these are the palliative care team people. They individualize the treatment plan. It really comes down to what the patient wants. It's interprofessional collaboration, no doubt, focusing on continuity of care and lots of communication and support. Here's what it looks like, the newer model. Diagnosis of serious illness and the goals of care are established. That's that question, what do you want? Okay, some people don't want what the guidelines say. Or they may know the guidelines and they'll do a part of the guidelines, but they also want to go this other direction. So you can see here that at the point of diagnosis, palliative begins at the same time curative begins. It just grows over time as curative care reduces over time. Then you have hospice, and then you have death, and then you have bereavement care. 7 major skills for people who do palliative care, and there's really nothing wrong with any of these for almost any kind of practice, to tell you the truth. So communication is a major skill. If you're not a good communicator, you're probably not a good palliative care person. Decision making, can you make a decision? Do you know how to present options in a non-judgmental, non-leaning kind of a way so that people can choose? Management of disease-related complications, symptom control, psychological and spiritual care. You have to understand care of the dying, and coordination of care or continuity. Those would be skill sets. Needs of palliative care patients. They want understanding of their illness and treatment options. They really want to understand what's happening to them. And you know, from talking to patients, so many people just do not understand their body. They don't really understand how it works normally. and in disease, it's even kind of more of a mystery to them, so they need interpretation. They need realistic expectations, not over the top, help making priorities for the future. They need care for themselves. They want to participate in treatment decisions, and they want a sense of autonomy and control as a way of coping with a serious illness. Nothing is worse than being sick and knowing you're dying and feeling like you're at the mercy of the people coming in the room all the time. You really need to transfer that sense of we're in charge of you to we're here to support you and help you how do you want to move. Okay. Communication challenges when delivering news. Okay. What are the biggest challenges that you might face in communicating to patients about serious illness care goals? It's not something that everybody is ordinarily comfortable with. Some people, I think, are better than others. So if you're sitting there judging yourself like, I can't do this, I don't want to do this, that's actually okay. This is not like everybody has to do this. Everybody has to be this. Everybody's not that. There are giftedness for certain types of communication, and then there's non-giftedness for that same type of communication. It's okay. You just need to know yourself. Just learn yourself and what you can do, and it tends to be the people who are good at it move towards it anyway because that's a very natural thing for them, whereas others very naturally avoid. If you very naturally avoid, just know that about yourself. It's okay. Bring in the people who are better at that part. Okay? So you can decide for yourself. You don't have to do this. The potential barriers to communication about serious illness, obviously the patient factors emotions and expectations. What if they're overly emotional? What if they're hysterical? What if they cry all the time? What if they cling to the earth with every power they've got and you just know there's nothing you can do? That's frustrating for a provider. So if you've got all that in the tank, it's just kind of like, oh gosh, it's kind of hard to deal with. Physician factors, and this would be true PA factors, any other provider who's interacting with them. Lack of serious illness conversation training. Nobody teaches folks how to do this. It's just not in the curriculum necessarily. Timing of conversations. When is the right time to do it? Uncertainty about prognostic accuracy. I don't want to go to somebody and start talking about end-of-life issues if there's a chance they might get better. And we're all trained to make people better to survive, so it's hard for us to throw away that. And what if we're wrong? What if we threw away too early? If we'd have done stuff that would live longer? So there's kind of that little guilt issue about, are you right or are you wrong? How accurate can you be about the final event for somebody? And a lot of times it goes deeper than it should simply because everybody's going to pitch until the last inning, keep swinging. Uncertainty of how to address patients and family psychosocial concerns. It's very difficult. That's another thing where people are gifted and people are not. When people start bringing a lot of emotional baggage or direction, a lot of emotional things, sometimes if you are busy, pressed, and stressed, you can't receive all this stuff from somebody else. You've got to be in a different space to be able to do that well. So palliative care people usually have enough, they create space for themselves so they can interact and do this. That's why the payment methods have to be there. You can't just do 20 palliative care cases in the morning and 20 in the afternoon. That's 40. It's impossible. It's just emotionally not possible to do it. Potential barriers to communication about serious illness. System factors. First of all, who's responsible? Who actually is responsible to do this? Which provider? You got a cancer doctor and a general internist and a blah, blah, who's the one who's supposed to do that? It's hard to know. You might actually, I've seen nurses do it. The nurse is more interested in the family dynamics and may see where they're going, and the family talks with her because she has been close with them. And she may go to the medical care team and say, I really think they're at a different place than what you're doing. Okay? Perfectly normal. It can happen. But who's responsible? I think sometimes somebody volunteers the role when they see what's happening to the family, and they really watch them. Life-sustaining treatment is a default approach in systems. When somebody starts crashing, it's not like it's do not resuscitate, because the assumption is you resuscitate. Why isn't the assumption do not resuscitate so that you have to put an R on the chart? Resuscitate, DR, do resuscitate as opposed to not resuscitate. Everybody thinks life is worth having. Well, I do too. Okay, but in certain situations, you're so trained to keep them alive, that that's your dashing in there to do stuff with people who don't need it. You remember the first part of this program, y'all did WIT, and they were crashing in where the woman didn't want to be resuscitated, and the nurse had to fight them back because they were going to do something that was not supposed to happen. Lack of a systematic approach to serious illness care planning, and the variation in location and quality of documentation of electronic health records. Our old arch enemy shows up one more time, is where's stuff written down about what people have said. You know, when there's an advance directive, it's in the medical record. They put it in the old records. It used to be the very back part of a paper chart. And in an electronic record, you have to go find the tab to get it. So it's, you know, there should be little red things like DNRs kind of show up in different ways on records, but all the rest of that stuff may not be there. So when somebody gets sick, really sick, it's always really important to read what all do they need so that your brain is kind of fixed on what needs to happen or not happen, because you're doing default to save them. Okay. Introducing the conversation. Okay, how do you do this care planning part? You ask for permission to discuss desires for future care. It's what the physician said on the screen. You just ask them, what would you like? You just have to be assertive and ask the question. Reassure patients about continued treatment. You don't want them thinking because I'm asking you about the end of life that we're going to turn everything off. We're not doing that. State support for the family and the patient, and emphasize that no decision has to be made during the initial discussion. Sometimes the best way to bring up hard conversations is just to approach gently and let people see how they respond and talk about it, and just let it land and then let it go. Okay, once you leave the room, it's in their mind. They will think about it. In fact, they've been thinking about it before you said anything, because people are not that disconnected. You read Ovid Illich, he was contemplating death way before he got to you and started to worry about stuff. So you have to just land it and then just get back and just come back, and then they'll start talking to you because you've opened the door of a possibility of discussion. Okay, here's some of the conversation guide. Understanding. What is your understanding now of where you are with your illness? That's the exact question he asked on the video I just showed. What is your understanding now? Patients don't always know where they are. Are you imminently near death? Do you have 5 months? You know, they're thinking different stuff sometimes. Information preferences. How much information about what is likely to be ahead with your illness would you like from me? Okay. Prognosis. Share prognosis as a range tailored to the information preferences. If they don't want to hear about the gruesome details on a ticking clock, you don't have to do that, but you can talk about your prognosis is likely going to result in death, and maybe within the next several weeks or so. Then go from there without getting more precise. Goals. If your health situation worsens, what are your most important goals? You've got to cover that. What are your biggest fears and worries about the future with your health? Function. What abilities are so critical to your life that you can't imagine living without them? And he, you know, the patient he gave example was, I want my mind to be intact. I want to know where I am. I want to be able to think. Okay, that's a high on my list. I really don't want to be unawares. That would really bug me. I kind of want to know what's happening. I want to feel good, but I want to be able to think. Trade-offs. If you become sicker, how much are you willing to go through before the possibility of gaining more time? Family. How much does your family know about your priorities and wishes? There's a way to talk to people called the Wish, Worry, Wonder framework. And this is just one example of it. The I wish statements always allow for aligning with the patient's hope. You know, what they've said, I wish. Okay, that's wishing for what they wish. Worry allows you to be truthful while sensitive. I worry about this for you. And then I wonder are subtle ways to make a recommendation. You know, I wonder if you might not like this. It's really, maybe this is what you should choose. But it's not saying you have to do it. It's I'm wondering. They will wonder with you, and maybe they've already wandered their way to the answer. So here it is in print. I wish, okay, aligning with the patient, we could slow down or stop the growth of your cancer. That's what they wish for. That's what the patient's hope is. And I promise that I will continue to look for options that can work for you. But I worry, okay, they're going to be truthful and sensitive. I worry that you and your family won't be prepared if things don't go as we hope. And then finally, I wonder if we can discuss a plan B today, which is, I think we should talk about a plan B today. Okay, so there's many directions you can go in a situation like this. You have to let the patient guide, but you do, it is appropriate and important to approach it. Okay, shared decision-making, collaboration in which the physician shares with the patient medical knowledge and opinion, and the patient shares with the physician values and preferences. You know, the physician on the videotape talked about we used to communicate what we thought you should do as the director, the paternalistic approach. Then it became the retail approach. We can do this, 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 and this. What do you want to shop off the list? And it's really some of both. Here's all the options. Here's the potential and potential problems with this. And they usually will say, "What would you do?" Well, in my experience, this seems to work this way. This one seems to turn out this way. I can't promise for you, but that's what it usually does. Okay, now that's being honest. They still get to choose, but they have more information. Two things I highlighted, the rest of it's kind of obvious. The patient's place as final decision maker does not imply the patient should be left alone in a maelstrom of medical information, and physicians must serve as critical interpreters of information, above all as reliable guides. Your role, one of your biggest roles as a PA is going to be to interpret the world for patients, because you will have time and you'll want to spend that time to help them understand what's happening in their body and where they're going. And you hear this repeatedly in healthcare situations that the PA is the one who helped the most. The physician is going to be bomb, 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 run, go, run, go, run, go, because they're billing for all this stuff and they don't have the time. Who's left behind to actually take care of the various issues and talk to maybe the PA in that case? So you'll be the one who helps people interpret stuff and really kind of help them kind of leverage them towards dialogues. Leverage the provider towards the dialogue too. So that's it. A lot to think about. Not fun stuff necessarily, but important stuff that you do need to know. All right, let's take 10 and then we'll come back and finish up.